Thank you very much, and we shall begin. So we'll start with a case presentation, then we'll do a little bit of a discussion of the case and end just with some conclusions and takeaway points. To begin, the chief complaint for this baby was respiratory distress. This is a former 35 and 1/7-week male who was the firstborn of twins and had been discharged from the NICU but was referred back to the ER by the pediatrician for evaluation of the respiratory distress. And at this point, he was 21 days old. So the symptoms began the morning of presentation to the ER. Mother noted poor feeding, wheezing, sound with the breathing, and then decreased activity. He didn't seem to have as much energy as his usual self. Now, his other male sibling was healthy and not demonstrating any of these symptoms. For the history of present illness, there was, and review of systems, there was no fever, no cough, and no known sick contacts. But he was noted to have stridor and retractions while the physician in the ER was taking the H&P. The vital signs on presentation to the ER were a temperature of 37.6, a heart rate of 149, a respiratory rate of 52, the blood pressure was 68/35 with a mean of 42, and the patient's weight at this point was 3 kilos. The oxygen saturations were 95 to 100% on room air, though the patient was still noted to have significant distress. Because of the significant distress, they went ahead and ordered a chest x-ray. The patient was given IV fluids, a dose of Decadron, and racemic epi to address the respiratory symptoms. This was the chest x-ray at this point that was obtained in the ER. We'll start with our first question. Which of the following findings is observed on the patient's chest x-ray? And I'll give you another chance to look at the chest x-ray. So your choices are a right clavicle fracture, neonatal pneumonia, airway narrowing, or a left pleural effusion. So most people went with C, airway narrowing. Very good. And so if you point out here with the arrow, you see that there is an area that seems to be narrow as compared in caliber and parameter. However, I'd like to bring your attention, if you look at a slightly different penetrance of the x-ray, you'll see that here there's a difference between the neck folds, so you can see a more fullness on this side as compared to the right side. So continuing with the case presentation, in terms of the birth history, this was a product of an in vitro fertilization. Mother was 38 years old. She had had 2 prior losses before the delivery of these twins. Her pregnancy had been complicated by hypertension and hyponatremia due to SIADH, which had required her to be admitted to the ICU, where she had been placed on magnesium and a labetalol drip, but otherwise her prenatal labs had been normal. She was GBS negative and there were no other issues. Because she was not improving, there was a C-section done for maternal indications, and for our patient, the APGARs were 8 and 8 at 1 and 5 minutes respectively. All of his birth parameters were essentially within normal range for a 35-weeker. During his initial NICU course, he had mild RDS requiring only CPAP. A patient was on room air by day of life 7. He reached full enteral feeds by day of life 5. And the other significant finding is that he had an intermittent systolic murmur during his hospital course, which had disappeared at time of discharge. But he was noted to have a left-sided superficial capillary hemangioma that involved his face and his upper neck. However, it had been unchanged during his hospital course. Now, his physical exam in the ER was noted for mild subcostal and supraclavicular retractions with some stridor. There were no murmurs noted at the time, and he had no significant abdominal findings. On his neuro exam, he was noted to have a diminished suck, but this was thought to be related to his respiratory distress, and they more specifically noted his stridor to be inspiratory in nature. Now, this is a picture of the lesion involving his face and neck. And then just to give you a more detailed description of the lesion, so these were extensive flat vascular lesions on the adult male beard distribution, which involved significant aspects of his lip, his neck, and his ear. There were also small lesions that were noted on the right side of his face as well, and there was a question of whether or not he may have some skin involvement on his abdomen. So looking at this patient again, the distribution of the patient's lesion most closely mimics which nerve? V2 of the trigeminal, the facial, glossopharyngeal, or V3 of the trigeminal. And just to show you the picture again. So most people went with V3 of the trigeminal nerve. Very good. Now at this point, what would you say the patient's most likely diagnosis is based on what we know so far? So very good. About 39% went with Serge Weber, and that would actually be the most common diagnosis that people would make, but in the case of our patient, it turned out to be Facey syndrome. So we'll go and talk a little bit more about that as well, but let me tell you a little bit more about the case. So ENT was consulted because of concern for airway compromise. As we pointed out with the chest x-ray, there appeared to be a soft tissue mass and some airway narrowing. And there did appear to be involvement of hemangiomas with the area epiglottic folds, and there was no involvement that affected the bilateral cord mobility, but no evidence of airway narrowing. It's important to note, though, by the time this ENT consultation was done, this was after the patient had received the dose of steroids in the ER. Hem-onc was consulted because of concern for facies, and they recommended a full workup, which would include an MRI of the brain, MR of the chest and abdomen, and echocardiogram. And at that point, they were considering propranolol therapy, but they wanted to make sure that there were no intracranial hemangiomas on MRI. So at the time, the MRI did not show any evidence of abnormality. The MRA was also without abnormality. However, the MRI of the neck and chest did show a right aortic arch, aberrant right subclavian artery, and possible coarctation. So we have a cardiac MRI protocol that we'll talk about a little bit more tomorrow, and this was unable to be done, so they couldn't comment specifically whether or not coarctation was present. Cardiology did get involved, and they did find a VSD, and they also commented on a mildly narrow aortic isthmus, but they weren't able to appreciate anything that would suggest a gradient or obstruction to flow. So they did not at this point call the patient an aortic coarctation. There was the right aortic arch with mirror image branching, but no evidence of a ring or a vascular ring. Ophthalmology was consulted with no ocular findings. We did send a chromosomal microarray, which did not return any significant results. And as far as this patient was concerned, he was actually discharged home on propranolol by day of life 6 with outpatient follow-up with all the consultants that had been involved. So he ended up doing very well. He was only briefly intubated and extubated back to room air and tolerated the propranolol therapy very well. So let's talk a little bit more about Facey syndrome. So this stands for posterior fossa anomalies, hemangiomas, arterial lesions, cardiac anomalies, most commonly coarctation of the aorta, eye anomalies, which are actually the most rare, unless you consider some people adding on the S to Facey syndrome, which is sternal malformations and supraumbilical roughing. So this was actually first reported in 1996. It was a case report with 5 patients. So this is still something relatively new. And I know for me, going through medical school, I was like, what's there left to discover? We learn about all these people and all these conditions named after them. So there are still things out there to think about. Now, we also want to mention Pascual Castroviejo. He initially reported the association between brain malformations and hemangiomas, but it was Frieden et al. Who put together the whole constellation of findings that you have in the syndrome. This is a neurocutaneous syndrome, and it is most commonly misdiagnosed as Serge Weber. There is a high preponderance of females to male, and the presentation can be highly variable. So how do you diagnose it? Well, you need a facial hemangioma that's greater than or equal to 5 centimeters and 1 major criteria or 2 minor. Then there's also possible Facey syndrome where you have the presence of the hemangioma and a minor criteria, or you have a hemangioma less than 5 centimeters with 1 major criteria or 2 minor criteria. And occasionally you can have just absence of the hemangioma and 2 major criteria. So looking at major and minor criteria broken down by system. So one of the things that's very interesting and very characteristic is persistent embryonic artery other than the trigeminal artery or persistence of the trigeminal artery itself. You can see evidence of moya-moya collaterals that will be present because of dysplasia or atresia of major head and neck vessels. And you can occasionally see saccular aneurysms of any of the cerebral arteries. There are also structural brain anomalies, in particular Dandy-Walker malformation. And with the cardiovascular anomalies, we've stressed coarctation of the aorta, but VSD is included with that, and aberrant origin of the subclavian artery with or without a vascular ring. Ocular findings are much less common, and usually you'll see some type of optic nerve hypoplasia. And then, of course, we've talked about the ventral or midline defects, but this can also include an ectopic thyroid or hypopituitarism. So this is just an example of an MRA, and what you see here is you see basically absence of the carotid artery, and you see a very tortuous posterior cerebral artery on the other side. And this is a sagittal view, which I'm not sure how well it projects, but you can see the face outlined here. So for our patient, would you say this patient now does not have Sturge-Weber, but either has definite or possible facies? Which would you choose? So our patient actually falls under definite. So his hemangioma was very extensive and involved his face and neck at greater than 5 centimeters. He did have the VSD, he did have a right aortic arch, and he did have an aberrant subclavian artery. So all of these would fulfill the minor criteria. And then there was the questionable of an aortic coarctation, which would be considered a major criteria. Aortic coarctation is actually very difficult to diagnose in these patients because of the aberrant subclavian artery, and a lot of times these patients may not present with symptoms until they're much older because you will not have a blood pressure gradient differential. So that's very key, and our cardiologists really continue to follow this patient and haven't given him a definitive diagnosis yet. So there is still some back and forth, but he more than likely will end up being definitively diagnosed with aortic coarctation. So just a quick summary of some of the conclusions. 98% of patients are going to have a hemangioma that involves the face or head. Any facial hemangioma greater than 5 centimeters, you should work up right away. And this would include an MRI of the brain, neck, and chest. You don't necessarily have to do an MRI of the abdomen, but you should at least do an abdominal ultrasound, because whenever you have a hemangioma greater than 5 centimeters of the face and head, you're more likely to have a significant hemangioma involving the liver. So that's a very important consideration. So what is the most common side effect observed with propranolol therapy in the neonatal population? So it actually is hypoglycemia. All right, at this point, I'm actually going to conclude just to save us a few minutes, but if anyone is interested in having my slides, which do have annotated notes, I'm more than happy to send those to you. Thank you.